Thank you for inviting me. It's great to be back here among people who have helped teach me a lot about CSF leaks, Dr. Shivank, and through his writing, Dr. Ulrich, and to join friends as well. And I think one of the very first articles I read about CSF leaks was Dr. Amuzagar's review. And so a pleasure to be here with you and to talk about this. One of the things that I've seen is that many people with chronic post-puncture headaches find a significant difficulty is getting their physicians to believe that this can exist, that it's possible, and to be taken seriously when it's 6 months out, 2 years out. And so one of the things I wanted to talk about was what's a differential diagnosis for someone who has chronic post-puncture headache? Can I give you a list of reasons why this happens so that that can be shared among patients and physicians, because it's easier to understand that something does happen when you understand all the ways that it can happen. With that, I'll show you this QR code that is a Google Drive folder that I keep and share. Inside that Google Drive folder is a subfolder on chronic dural puncture headaches. It has, I think, what I consider the 9 best articles documenting the occurrence of this problem, and other things like a contact information spreadsheet put together by Duke and Stanford and others for physicians interested in helping people with CSF leak around the world. I'll show this at the end of the talk as well. So with that, let me jump into what I see as 4 principal causes of persistent CSF leak despite a properly done epidural patch. And those 4 things in my mind, and hopefully this list will continue to grow over time as we talk to each other and share images and share experiences. The intact plica mediana dorsalis, I'll talk about what that is, a ventral dural puncture, a dural fistula formation, and a dural bleb formation. And I have this 5th thing down here that I haven't really included in the 4 causes because we don't really know. This has not been documented. We know that you can, during an acute puncture into a vein that's epidural and create an acute little fistula, but we don't know if that contributes to chronic low pressure headache after a dural puncture, at least not to my knowledge. Maybe Wouter will jump in if he knows of a case. So failure point 1 for why a properly done bedside epidural blood patch would not work is what I would call a functionally intact plica mediana dorsalis. So this is a fibrous tissue band that exists in some, perhaps many people in their epidural space outside the bag. One example is illustrated by this case, a 35-year-old woman who had a spinal tap. After the spinal tap, she had a spinal headache rated at 10 out of 10, had at least 1 failed blood patch. Her MRI of her brain is very unremarkable. She would not meet the old, really current SEEPS criteria. She did not have subdural. She did not have pachymeningeal enhancement. There was no discernible sagging. Dr. Ulrich will look at that and say this is perhaps one of the cases that one of his papers would address. So Dr. Ulrich there in this paper from JAMA Neurology just a couple of years ago participated in research that showed some of these distances, the distance between the top of the pituitary and the optic chiasm and the mammato-pontine distance here and the prepontine distance here, do in fact increase the likelihood that somebody has a leak if you see those things. And when we look closely at her brain MRI, she in fact met 2 of their criteria for a low mammato-pontine distance and prepontine distance. This was the image from the dural puncture that caused her then chronic headache, because I was seeing her 10 years later. I couldn't really tell from this if it was on the left side or the right side of the midline. It's close to the midline, but this isn't a perfectly midline view at that level. When we, in fact, went to patch her, you could see after we put in our needle and injected contrast, that the contrast, this dark hazy stuff here, spread up and down, but not at all to the right side. Often people will have a little kind of fibrous band here. So we put in a second needle here, and that's what it looks like after injecting in that second needle. So this is somebody who needed a second needle on the opposite side of midline to get adequate spread across half the interspace where she had her known dural puncture. And that can lead you to do things like this. This image is from a young woman who had a severe low pressure headache after having a lumbar drain removed. We weren't sure if it was at this interspace or this interspace. We could see a skin suture that showed us where the lumbar drain had been sewed in, and it was at about this level. We started by injecting these needles on the left, and what you can see is we have excellent spread across 3 separate interspaces, but it's all confined to the left side. If this was a bedside epidural blood patch, we'd have great spread on the side that we happen to land on and none on the opposite side of midline. This is what it looked like when we injected on the other side. We were able to get full coverage. And so some people, because of an intact plica mediana dorsalis or other structural reasons, when they get a properly done blood patch, they will just not have spread across the midline, even though they'll have spread up and down across other levels. So a properly done bedside epidural blood patch may do nothing to cover or seal the defect in this circumstance if the defect happens to be on the opposite side of midline. The patient will nonetheless feel better initially with the properly done blood patch, and then their problem will recur. Why is this? So we know that injecting volume into the epidural space without actually sealing or covering a defect pressurizes the bag of fluid temporarily and causes some temporarily remission of symptoms. We've known this for a long time from studies that suggested that epidural saline, simply putting saline in the epidural space, resulted in pain relief for people with post-dural puncture headaches. But of course, it has no effect on sealing the defect. And when they started using blood, it became immediately clear that blood was more effective than epidural saline for post-dural puncture headaches. So there's 2 things that the patches do. They pressurize the bag, which will happen whether or not your sealant reaches the defect. And then there's a sealing or covering of the defect and sealing the defect effect, which will only happen if your sealant, blood or glue, happens to cover the defect. And so a patch like this, if done with high volume, or a bedside patch on one side, will certainly make the patient feel better temporarily. And then the problem will recur because you didn't actually seal the leak. And so this will lead to a lower long-term patch success rate and artificially inflated estimates of early success. In this case, simply repeating the procedure simply repeating a bedside patch would have given a 50% chance of covering the other side, because you're always trying for the midline and you always land just to the left or just to the right of midline. So the thing to do is to either repeat the patch or to use a bilateral paramedian approach using epidural guidance. Now, this idea that you might in fact have lower long-term success than you anticipate, illustrated by this paper by one of my colleagues, Dr. Flood. She looked at 40 cases of people who had had an accidental dural puncture and 40 controls who had an epidural the same day but didn't have an accidental dural puncture. This was the incidence of chronic headache 12 to 24 months later. And what you see is among the controls, the patients who had a baby and had an epidural but no known dural puncture, the rate of new chronic headache is only 5%. But if you had an accidental wet tap at a major university that was recognized and thought to have been treated appropriately, the likelihood of new chronic headaches was close to a third, 28%. When they broke that down by whether they were given conservative treatment or a blood patch, what you can see is the patients who were given no blood patch had a 40% incidence of headache. And those that had received a blood patch had that cut in half to 20%. It's interesting to me is that, we were taught when I was an anesthesia resident that a properly done epidural blood patch is 90% effective for a post-dural puncture, but it appears to only be 50% effective for reducing long-term complications. And 50% effective is what you'd expect if half the time you land on the right side of midline, half the time you land on the wrong side of midline. The other thing to notice is, remember, the control rate, those who didn't have a dural puncture, was 5%. Even if you were recognized and given a blood patch, your rate of having a new chronic headache a year later is 4 times the background rate. What's failure point two? The failure point two is a ventral dural puncture. So that same woman who in fact had her lumbar puncture 10 years ago, when you looked at the laterals, it looked to me like maybe in fact that needle got to the ventral dura. What I was worried about was that it was this, that the needle had come in from the back, penetrated the dorsal dura, the back part of the dura here, gone through the bag, and then put a hole in the front surface. And why is that important? Because this image was published by Dr. Shivink in his JAMA 2008 review, and it shows how when you do an epidural patch, you may in fact only get coverage of the dorsal dura, which is great if you have a dorsal puncture, and not so good if where you need to get your sealant is here. So you want to do what's called a transforaminal approach, come in from the side to get your sealant here. And that's what it looks like in this patient's fluoroscopy. This needle here was the one putting blood on the back surface, and then we came in from the side, and you can see contrast spreading in the epidural space on the ventral surface here to cover that potential problem. Another case of this was an 18-year-old who was recently transferred to Stanford Hospital for a recognized unintended dural puncture during labor. They had failed 2 epidural blood patches, good subdural hematomas here, little acute on chronic bleeding, some on the other side, maybe a teeny little bit of midline shift. And this is what their spinal MRI showed. And what you see here is the red arrow shows where the dura is, and the blue arrow shows that in front of the bag, there is a ventral collection. The sagittal image doesn't really show, did they do their puncture here or down lower? And that's important because this was now a month later, and the likelihood your patch is going to work a month later is substantially lower. And we wanted to give this woman, especially with her enlarging subdurals, a chance for a definitive repair with surgery. And so we went ahead to try to figure out exactly where the ventral puncture was. We did something called a digital subtraction myelogram, something that was taught to our radiologists by Dr. Shivink and his colleague Marcel Maya, who spent time on the phone with our radiologists. This is what it looks like, and you can see the needles coming in here, contrast spreading in the bag here, and then this little thing here where the contrast was starting to extravasate out, allowing us to localize it at L2-3. You see it there with another image a second later, extending. And that's Marcel Maya there with Dr. Shivink. Again, appreciate their help in teaching us at Stanford how to do this. This allowed a surgeon to go in there, open the dorsal dura, look at the hole in the ventral dura, repair it, and then repair the dorsal dura on the way out. So a properly done epidural blood patch, again, may do nothing to cover or seal the defect. If it's ventral, the patient will again feel better initially after the patch because you've pressurized it, and then recur because it's not sealed, again leading to lower patch long-term success rates and artificially inflated estimates of early success. Unlike the plica mediana dorsalis situation, simply repeating the patch here is unlikely to help. You're not going to land on the opposite side of midline and fix your first failure point. So this is something that's going to require you to either do a transforaminal approach or special imaging to give the surgeon confidence that they should not only explore this, but when they explore it, not just look at the dorsal dura, but open it and go inside and either scope or visually inspect for a ventral dural defect. Failure point 3 would be a dural fistula formation. So patient Lynn, who was a physician, had a venous sinus thrombosis and a venous infarct with hemorrhagic conversion. Essentially, she had a stroke. She had a right frontal craniotomy, evacuation of the hematoma, and had a lumbar drain placement. This is a tube that gets put in the through the dura to allow spinal fluid to escape to reduce intracranial pressure. After a year of having an orthostatic headache, she was worked up for a persistent leak. She had a radionuclide cisternogram, which showed no evidence of a leak. She went to Mayo Clinic. They did bilateral digital subtraction myelograms since her MRI showed no epidural collection. So they were looking for a fistula. They did bilateral digital subtraction myelograms, no evidence of CSF leak or fistula. She had multi-level thoracic epidural blood patches at Mayo without relief. And we went ahead and We suspected she had a leak from the lumbar drain, and this is what we found when we patched her. So this is one of my first patches. The needle is coming in here at 3-4, and usually you can tell, not always, but usually you can tell if you've caused an accidental dural puncture. I was pretty confident I had not caused the dural puncture, but here I am seeing CSF get intrathecal. And I thought, it's certainly possible that that's me, but I think that actually what I'm seeing is my contrast entering the thecal sac from a fistula. But how would I go about establishing that definitively enough for a surgeon to go in there? So we brought her back later, and about a month later, did it again. So there's the intrathecal fluid that entered from the epidural space. And this is a repeat of the patch. This time I've come in deliberately a level below, injected a large volume of contrast in the epidural space to get it to spread up to where I thought the fistula was. And you see this little faint line here that appeared on the digital subtraction images. And that was enough to get our surgeons to go in there, and they found this. This is a hole, but you'll notice the edges are not ratty. They're not unhealed edges. These are not edges that are looking to try to heal themselves if you just cover them with blood. They're well epithelialized, healed edges. This is a fistula. It's not a bleb, doesn't show up on a myelogram as filling with contrast. It led to no epidural collection, but putting a suture in that fixed this woman's problem. Again, properly done epidural blood patch is not going to seal that defect. The patient would feel better temporarily from just pressurizing the bag. Again, repeating the patch isn't going to fix this, and you have to consider doing what I did, which is digital subtraction images in the lateral projection to look for intravasation of contrast. If you're doing this under CT, one of the things you might consider is doing a pre-patch measurement of Hounsfield units in the spinal fluid, and then after injecting contrast, a post-patch look at the intrathecal fluid to see if you can detect subtle evidence that contrast entered the spinal fluid. And then failure point number 4, which I think Dr. Ulrich is going to talk more about, is dural bleb formation. This is my little favorite case. This was a patient who had a spinal cord stimulator placed with a known accidental dural puncture. She developed chronic headaches, and you can see her spinal cord stimulator lead sitting outside the dura there, and right next to it, the dural bleb that caused her to lose 60 pounds as she vomited 9 times a day over the course of 18 months. She's now a med student. That's what it looks like at surgery, and with the suture put in it. I think those images might have come from Wouter. Again, that's a patient in whom repeating the patch is not going to fix the problem. They needed a repeat CT myelogram. This wasn't detected on their first. Very fine cuts, often assisted by getting pooled, undiluted contrast to mix here. And you really have to exhaust patching and push for surgical exploration. So I've shown you 4 causes. I'm not going to get back to the CSF venous fistula thing. I do want to take 2 minutes before I close to talk about one more thing. It may not be clear exactly when you've caused a post-dural puncture headache. We make assumptions in our favor about the frequency and severity of post-dural puncture headache all the time. This was a study published by Goldsmith, a prospective cohort study of post-puncture headache in 985 women. And what they identified is that when they looked at these nearly 1,000 women postpartum, that something like 381 had postpartum headaches. They then decided to break them down based on what we know about headaches, about what kind of headaches they were. And you can see, in fact, that the vast majority of these headaches are, in fact, tension type or migrainous or musculoskeletal. You see way down here, only 18 of those 381 headaches, or about 2% of the total, were post-puncture headaches. 4.7% of all the headaches were post-puncture, but it represents essentially 1.8% out of the 985. The point being, almost all of the postpartum headaches were attributed to causes other than post-puncture headache. But when you read their paper, what you see is that they say that although we only diagnosed 18 post-dural puncture headaches, 81 of the 381 women reported symptomatic relief when supine. So for every one patient they actually gave the diagnosis of post-dural puncture headache to, there were 5 others who had symptoms that maybe should have been attributed to post-dural puncture headache, but had migrainous features or other features that sounded like a different kind of headache. And a well-meaning neurologist evaluating them was going to give them an alternative diagnosis. And so I think that this is evident in other papers as well. This is a randomized control trial looking at different kinds of needles to reduce the incidence of post-dural puncture headache. And this little, I'll just read this from the abstract. The incidence of all headaches during or prior to discharge was 11%. Only 5 headaches, 0.75%, were severe with features of post-dural puncture headache and required an epidural blood patch. So we discount, we don't want to believe that the incidence might be as high as some of the symptoms suggest. And so there's really 2 ways of determining the proportion of postpartum headaches that are attributable to a dural puncture. Method 1 is you take the features you know are associated with post-dural puncture headache, and you count these among total headaches, like orthostatic, postural component. You take the feature you know is associated with post-dural puncture headache, and you count those among the number of total headaches. This is what has been done. The advantage is it's easy. You don't need a control group. The disadvantage is it's based on assumptions, e.g. that post-dural puncture headache will be postural. And the disadvantage is we repeatedly and systematically assign ambiguous cases in our favor. What's an alternative method? An alternative method is you count the number of headaches among those postpartum patients who had a needle in their back. And then you count the number of headaches in a matched postpartum group who had no needle in their back. And then you calculate the excess number and proportion of cases, headaches, attributable to having a needle in the back, independent of what the headache looks like, i.e. you don't make assumptions that only post-dural puncture headaches are going to be postural or vice versa. So you get to count the excess occurrence of headaches, and then you work back from that to determine what % of post-dural puncture headache is postural. The advantage is your conclusions are more reliable and free of bias. The disadvantage is the methodology is much harder. And there's a role here for quote unquote pseudo randomization. People who wanted an epidural but could not get it because they arrived, for instance, at the hospital too late to receive one before they delivered. The point is, our current methodology is this. The right way of doing it is this, and no one's done this. And so we really don't know what percentage of those 381 headaches are excess headaches that would not have existed had the patients not had a needle in their back. And with that, I will close. Thank you very much.